C'est magnifique. C'est notre vice-président qui va introduire notre orateur suivant.
Donc la parole au docteur Donald Reid, qui vient du Lanarkshire, c'est une région d'Écosse, j'imagine, l'école écossaise de chirurgie vasculaire.
Et qui parle en français. Non. Non, en anglais.
Bonjour.
Nice to meet you.
Bonjour, messieurs et mesdames. It's okay.
My friend.
Donald is a very famous surgeon from Scotland, from Glasgow. He's a friend of Andy Murray, by the way. And everybody knows the family in Glasgow because grandfather was doctor, including your dear brother Alan, who passed away. I know you in Phoenix. We are still friends since 30 years. You've been president of the Society of Dr. Dietrich just after me, and we are very happy to welcome you in Paris. You like Paris, you like Roland Garros. You are like the old alliance that you are part of. Thank you very much.
Thank you.
Vieille alliance. It's better I speak in English if you forgive me. I'm a vascular surgeon. I'm Scottish. And Jacques Bousquet has asked me to talk to you a little bit about what he calls the Scottish School of Vascular Surgery. And so I would like to tell you a little bit about the recent history of vascular surgery in Scotland, the people involved, and also a little bit of the ethos or principles of surgery. So as you've just heard, I've known Jacques Bousquet for 30 years. I regard him really as a great ambassador for vascular surgery all across the world because he loves vascular surgery and he's very, very good with people. He brings us together, not just in France, but all across the world. This is with my colleagues, my friends that I work with at home. Some of you may have heard of Hogarth Pringle if you're a general surgeon because of Pringle's maneuver. Are there any hepatobiliary surgeons here? Pringle demonstrated that you could control the blood supply to the liver. At any rate, he was in Glasgow Royal Infirmary in Scotland, and in 1912, he operated on a young man who had a popliteal artery aneurysm, a huge aneurysm. And he removed the aneurysm and he put in an interposition vein graft. He sewed in a vein graft in 1912. This at the same time as Alex Carrel got the Nobel Prize for doing the same in dogs. But this was one of the very first reconstructive vascular operations. He also did the same year an axillary vein replacement for an axillary artery occlusion. And he operated on the 5th floor of the Royal Infirmary. So that was one of the very first things that introduced vascular surgery to Scotland. And it took many years until after the Second World War until aortic surgery really began in the 1950s. And I think Jacques showed a photograph of Dubost. Dubost came to visit Mr. Reid here in Glasgow. This was at a time in the 1950s where there really were no vascular grafts, artificial vascular grafts. And the very first aortic case in the UK was a man called George Sargent. He was a Glaswegian. He was waiting in the ward. People didn't know why, what was going to happen to him. And he would say that he was waiting for a healthy cadaver. He was waiting for someone to die that could provide an aorta. And it was freeze-dried in those days. But the results were not good. So my father, Mr. Reid, went down to London, and he went to the best tailor in London, and he bought 2 shirts. And he came back and asked his theatre nurse to cut the tail off the shirts, pain de chemise,
And they rolled it up into a tube and they sterilized it overnight. And Mr. Sargent got the very first graft from a shirt. It was very successful because many years later, I operated on his son. So this began a lot of aortic surgery in Scotland. And at the same time, there was a technique that was also developed locally called chemical sympathectomy. And you may not know, but the late king, that's the Queen's father, King George VI, as well as dying of lung cancer, he had gangrene, and he was treated with an operative sympathectomy very successfully. But this is a technique where you lie the patient on their side under local anesthetic, and you inject phenol into the lumbar sympathetic chain to achieve the same results, and it's very minimally invasive. And this is a publication in 1970 of 1,000 cases. And I've done about 1,000 of these. I don't know whether Jacques does this in France, but I do this for ischemic rest pain still and for intermittent claudication. You can use X-rays to determine exactly where to go. So that's, although it's a very old-fashioned technique, it still is applied today. The very first case of intra-arterial thrombolysis in the world was in 1963. And again, this was in the Royal Infirmary. This was a lady who came in with a cadaverous ischemic arm, a white arm. And you can see on the left-hand slide, there's clots in the brachial artery. And below the elbow, there is no contrast, no X-ray dye. And so a small incision was made in the arm, and a catheter was pushed down over a whole weekend to infuse streptokinase. And you can see she got a great result. The woman's husband was so pleased about this. Streptokinase was very expensive in those days, and he called her the woman with the golden arm. It was so expensive. But this was maybe the introduction of endovascular surgery. So another surgeon called John Pollock, who's on the left-hand side here, he went over to Dr. DeBakey and Dr. Cooley in the late 1960s, and he came back and very much pushed more and more aortic surgery. And he formed a company that some of you may have heard of called Vascutech. It's now called Terumo Aortic. And he introduced this knitted Dacron graft. It's sealed to prevent blood loss. And also later, the endovascular graft called the Anaconda device. And just to give you an idea, the unit's results really for ruptured aneurysm over the years has maintained very consistently about 39% mortality for the patients getting open surgery. For elective aortic aneurysm, it's 1.9%. For the endovascular repair, we just wrote up a series of about 250 patients, 0.4 30-day perioperative mortality. So those are local results. In 1994, this is Alan, my late brother, who with John Pollock opened up the first endovascular suite. And this very much was able to allow us to operate inside people's arteries using X-ray control in the room. And this really led to great collaboration with Dr. Dietrich, who Jacques Bousquet has told you. He went to be a fellow there before I did. I went in 95, 96. And he really was the pioneer of endovascular surgery, as well as being a very, very strong open surgeon. He did cardiac surgery, he did thoracoabdominal surgery, as well as peripheral vascular surgery. And when I came back, one of the things that I was very, very impressed with was this technique called intravascular ultrasound. And a small catheter is pulled through. This is the iliac artery. And it shows you the degree of narrowing. It's extremely powerful at showing you the severity of arterial disease that the angiogram does not always show. So that in 40% of cases where we would do a completion angiogram, When we use IVUS, we'll find that it's not good enough. And so we'll need to treat it more. Maybe it's another stent, improve the stent. And I found this a very, very helpful thing to bring back to Scotland. One of the principles from many, many years has been the power of profunda. It's a phrase we would use, the power of profunda. But on the left-hand side, you can see that the aortoiliac disease has always been treated by a bypass down to the common femoral artery. Usually you have to remove the disease into profunda. And it's an endarterectomy of profunda, and then you put the graft over. And really what I noticed when I was able to come back from Phoenix in '96 was to change this into stopping doing so much aortic grafting and simply do an endarterectomy in the femoral artery, and then put the IVUS catheter up and put the stent in to relieve the aortoiliac disease so that the patient did not need such a big operation. That's one of the ethoses that really has changed slightly. And then coming back from Phoenix, we developed the endovascular treatment. This is the first case I did for a fenestrated aortic aneurysm. And you can see here that I've got catheters into both of the renal arteries because the aneurysm does not have a neck that we can put a standard endovascular graft into. Here's a patient from Pakistan who had a thoracic aneurysm. Now, your Dr. Kiefer would have done this as open surgery. This patient had an endovascular graft put in and was able to go home the next day. And here is some carotid stenting. I know that Jacques Busquet was very keen on this. Our results with carotid stenting were exactly the same as for carotid endarterectomy. So my stroke rate for carotid endarterectomy was 3%. And my stroke rate for carotid stenting was also 3%. We found intravascular ultrasound, again here, very good at showing the degree of narrowing beforehand and then showing how well we've treated the stent. So briefly, our principles have been to try to get proximal aortic surgery, the benefit of the best circulation into profunda, and marry. I heard the discussion earlier of trying to, when do you do endovascular, when do you do open surgery? I think the best answer is if you're a surgeon that does operative surgery and endovascular surgery, you can choose what the best one is rather than only be able to do one or the other. And I would say to you, I think sympathectomy still has a big role in what is done today. It's a great pleasure to be here, Jacques. Thank you very much for inviting me.
Thank you very much, Donald, for this extremely good report of your experience in Glasgow on vascular surgery. I've been lucky to be invited by your family and yourself to the Royal Academy of Edinburgh. And I know that you have a principal in vascular surgery. You have a very good school. At that time, in the 19th century, you were one of the best places to be trained, better than US and equal to France. So I would like to thank you to be with us. I hope one day you will postulate to be member of this academy. You deserve it. If
it's open to you.
Thank you very much.
Thank you.
Very kind.
I will sponsor you if you need. And we like you very much. And please go.
I'll practice my French.
We have to go on to this good friendship and collaboration. Thank you very much.
Des questions pour Donald? Donald, don't go. Perhaps you have some to answer to some questions. Ronald de Virag, you know Ronald Virag, he's here.
I've met earlier today, yes.
I am quite the oldest here, and it's a long time that I have not heard about sympathectomy. So I want to know what are the indications, because we have done so many and they were abandoned completely after.
In France, it is quite abandoned.
No. Quite abandoned.
Not? You continue to do?
But what are
Totally
the
convinced that
indications?
there is still a place of that because I'm coming from Strasbourg, and of course with René Lerich,
Yeah.
it was one of the
Yeah.
fundamentals of our specialty. So no, I think that there is still indication for that, not all day, but
what are the indications today?
critically mixed.
Have you actual guidelines for that?
We have.
What is your recommendation?
Yes, we do.
International recommendation?
Yeah, good. I'd love to answer the question unless Jacques wants to.
Dr. Chapuis, Professor Chapuis, do you remember one of your case that we save from a stat 4 ischemie? Can you give a word on what we did?
Il y a Jean-Claude Coffinal aussi qui veut. You have a
You remember?
Jean-Claude.
Oui, there is an.
In English, Jean-Claude.
Yes, there is an objective examination to know if it's very useful to practice sympathectomy. It's the hyperemia at the Doppler. If the test is positive, you have a flush and you have a vasodilatation, and you know that your procedure is going to work.
Fabien, do you practice sympathectomy since you are so active?
In many cases, sympathectomy alone can bring you a stage 4 ischemia into the conservation of the limb. But I think the best indication nowadays for sympathectomy is to open the outflow for a difficult distal bypass. When you see only one axis and in some cases a part of one axis in the limb, and you do a bypass on this limb, previous sympathectomy can save the life of the limb and sometimes the life of the patient.
I think the answer to your question is the indications are ischemic rest pain and gangrene and intermittent claudication. But I would not use this for everybody. I would try to find a direct operative repair, either aortic bypass using profunda to try to save the leg, or an endovascular stent, often using profunda, the power of profunda. But as you have said, when the runoff is poor, when there is distal disease, it's a very good thing to do. In aortic surgery, if we see there is not good runoff past the femoral artery, we would do at the same time as an open aorta, a lumbar sympathectomy. And in a retrospective review of our last 1,000 aortic grafts, the patency rate of the aortic graft was statistically significantly improved if they had had sympathectomy. So it does have an effect, but I completely agree, it is not the flavor of what people do nowadays, but it's nice as a surgeon to have a bit of endo, a bit of open, and a bit of sympathectomy. It's helpful to have.
Dr. Reid, I have a question on your presentation I enjoyed very much. The relationship between the Scottish School of Vascular Surgery and the creation of Vascutech, because it's a fair example of what has to be done for European surgeons to bring in Europe an industry for vascular surgery.
Well, John Pollock did this. He started in 82. Over 1 million patients in the world now have had a Vascutech graft. They have continued to develop into endovascular. I think it was easier in those days than it would be now to develop a vascular graft. But he was a hard worker. He was a great surgeon, probably the best operative surgeon I've ever seen. He taught me, and he worked out that the velour that Dr. Cooley had was the wrong way around. He felt that he had a very small velour on the inside of his graft, John Pollock did. And he used the gelatin sealant to save blood loss. He preferred knitted material and woven because it was better incorporated, easier to sew in. So, yeah. But the French have got good companies too.
I want to thank you about Edouard Kiefer, because you have spoken about his presentation about the complex arch surgery, combining surgery and endovascular techniques. And he was a master on this field.
Yeah, lovely man.
And he was our master.
Was he?
Yes.
I also met René Fontaine once, many, many years ago. He came to our house, and Debost came to watch my father operate. So there is an old alliance.
Of course.
Thank you very much.
Thank you so much. The Academy is very proud about your presentation, because Scotland, it's a part of our culture. Thank you.